Welcome to EuroPCR 2017. I'm here in Paris together with Dr. Mel Lobo from London. Hi Mel.
Thank you, Felix.
We have a couple of minutes to chat about the changing landscape of hypertension and what it means for a daily clinical practice. Mel, SPRINT has been published, new guidelines for hypertension are around the corner. Tell us in a nutshell, what is important to know as an interventionalist about blood pressure measurements and probably about blood pressure targets?
So for the interventional community, I think the key thing is fidelity of blood pressure measurement, and you guys are already very keen and hot on high quality measurement of coronary flow and imaging techniques. Blood pressure, as important if not more, has to be measured correctly, and the big message I think is that we need to be measuring blood pressure not just in the doctor's office but out of the doctor's office. And there are two reasons for that. We can have patients whose blood pressure is falsely elevated in the doctor's office, the white coat effect, but we also have a group of patients, maybe as many as 30% of all comers, whose blood pressure is normal in the doctor's office but elevated when they're away from the office. And these people have been proven to be at increased cardiovascular risk. So the important theme is blood pressure measurement out of doctor's office, either with ambulatory blood pressure monitoring or home monitoring.
So should we abandon office blood pressure measurements then?
That's a really good question, and it's something I think about every now and then. I think we need this for the time being because there are practical issues to undertaking ambulatory blood pressure monitoring at scale in large populations, as well as the fact that not everybody can afford a home blood pressure monitor, not everybody feels comfortable measuring their own blood pressure at home. So for the time being, the office measurement must persist. But I think the other message is that we must standardize our office blood pressure measurement. And in this respect, the SPRINT study has really thrown up a major challenge in the recent past with its publication.
Can you remind us, 3 words on SPRINT, what the outcomes were and what the impact for you in daily clinical practice is?
Well, SPRINT showed that if you treated patients with intensive blood pressure goals compared to standard blood pressure goals, there were improved outcomes, mainly in heart failure reduction. And they did manage to achieve a on-treatment blood pressure of systolic blood pressure of only 120, which is excellent. But there were quite a lot of downsides to achieving that in terms of side effects from medications, and this required frequent clinic visits for medication titration. And the other major point about SPRINT is that the method of blood pressure measurement is unique amongst clinical trials. The investigators chose to use a technique called unattended automated office blood pressure measurement, in which the patients were left in a room to settle for 5 minutes whilst the device was attached, but then the recordings of blood pressure were not made until the 5 minutes had elapsed, and thereafter 3 recordings were made. This has actually produced blood pressure results from the SPRINT study, in which office blood pressure is actually lower than the ambulatory blood pressure at the same period. And this has never been shown in a clinical trial before. So I'm not quite sure where the SPRINT blood pressure levels leave us in terms of informing current guidance with a differentiated blood pressure measurement technique.
But in daily clinical practice, what is the blood pressure target that you are shooting for?
This is an excellent question. I mean, at the end of the day, we are still debating furiously on optimal blood pressure targets, and we have guidelines from around the world. The US has several sets, Europe has its own set, UK with NICE has its own set. And I think I'm pretty happy to settle on the ESC, ESH guidelines from 2013, giving us an optimal target of less than 140 for systolic, less than 90 for diastolic, and I don't see any reason to change that in all comers. In the elderly, we're happy for a target of less than 150 systolic. We relax a little bit, and in patients with diabetes, you might argue that it's reasonable to have diastolic blood pressures in the 80 to 85 millimeters range, consistent with the findings from the HOT study, but by and large 140 over 90 to keep things simple. And one has to remember that aiming for very low targets in blood pressure is not always straightforward. You induce a lot of side effects of drugs, and patients need to be monitored carefully.
The main question though is, I mean, if you agree on 140 over 90 as the target, how to bring patients to that blood pressure value? Is there an easy approach to get patients to control, or what is your algorithm in your daily clinical practice to bring patients to control?
So what clinical practice teaches us is that there is no easy way to achieve blood pressure targets, and that's why we see such wide variance around the world in blood pressure targets in the various populations, even in the established market economies. And I think one has to combine a lifestyle-based approach with a drug-based approach, and the drug-based approach should be with guidance. And what we're learning is that patients don't necessarily adhere to lifestyle, and they're certainly quite frequently non-compliant with medication. And this leaves us now needing the help of interventionalists to design and investigate studies of device therapies of hypertension so that we can offer patients alternatives to drugs.
How many patients in your daily clinical practice are non-adherent to antihypertensive medication?
Well, we've been shocked recently by some work that we've been doing on urine toxicological assays to look at adherence properly, objectively, and this has demonstrated to us that as many as 75% of patients with resistant hypertension who tell us that they're coming to the clinic and taking all their medications are actually taking between 0 to 75% of their medications. So the rates of non-adherence, even in a specialized clinic, are surprisingly high.
Well, with the development of device-based therapies a couple of years ago, resistant hypertension moved on center stage back again. Do you think that terminology is still relevant and that we should keep that definition of patients being uncontrolled despite the intake of 3 antihypertensive drugs, or would you recommend overthinking this definition and getting it more patient focused and saying, okay, patients non-adherent are also in a kind of resistant if they resist to take antihypertensive drugs? Do we need to change that?
Probably we do, but the issue here is how do we measure non-adherence? And the fact is that at the moment there is no large-scale applicability to the technologies used for measurement, and they can be expensive, requiring spectrometry. So I think it's a very good point that you make, and I've never been that comfortable with the term resistant hypertension because I think it excludes a lot of patients who might benefit from device-based approaches. And I prefer to use a term of uncontrolled hypertension. And that also allows patients to express a preference for not wanting to take antihypertensive medications, either due to belief or side effects. And I think the big issue here is that unless we give patients a little bit more choice in their hypertension therapy, we're going to always struggle with the adherence issue.
That's a nice conclusion. Thank you very much, Mel. Thank you for discussing with me the changing landscape of hypertension. We have heard about the SPRINT trial that brought patients to a lower target blood pressure and that improved outcomes in these patients. We have also discussed potential blood pressure measurement modalities, but we also agreed that the SPRINT trial has no immediate impact on clinical practice, at least in Europe. I think we have to consider that patients are at high risk whenever they are uncontrolled, and we need to offer those patients new approaches and approaches that reduce their cardiovascular morbidity and mortality. We have to take adherence into consideration. I think all these are aspects that impact our daily clinical practice, and with that, I thank you very much.
Thank you.